Good morning, everyone. I'm Cecilia Zalkin, President of Advocates for Children of New Jersey, and I'm thrilled to be here today to introduce our second town hall meeting in partnership with Melanated Moms, this one on maternal and infant health in the pandemic, but also during this time of civil unrest. Um, our partnership, we're very excited about our partnership with J. Madden Wilson and Melanated Moms to bring parent voice to our advocacy agenda. For those of you who don't know ACNJ, we're a statewide child advocacy organization located in downtown Newark. We do not provide direct services, but we advocate on the state and federal level to ensure that every child in New Jersey has the chance to grow up healthy, safe, and educated. Over the last 3 years, we have focused our attention on what happens during the earliest years of life, prenatal to age 3, believing, as I'm sure you all believe, that this is a critically important time of life and needs to be supported with high quality childcare, support to families, as well as access to healthcare, prenatal and early healthcare, both physical, behavioral as well. We have an agenda that we just announced called Unlocking Potential, because we also strongly believe that getting it right from the start and supporting children and families right from the start is also an equity issue. So I am thrilled to be here today. As I mentioned, this is the second town hall meeting that we've done with Melanated Moms. Last Wednesday, we did a very engaging conversation about childcare during the pandemic. And I have to say that all week I've gotten so many positive comments and responses from people who participated in that town hall meeting. So we're very excited to be here again today to look at a new topic around maternal and infant health. I'm going to turn it over to J. Madden Wilson, who heads Melanated Moms, and let her introduce the topic and the panel a little forward. I'm looking forward to the conversation, and thank you all for joining us today.
Good morning, everybody. My name is Jay Wilson. Thank you so much, Seal, for that wonderful introduction. I'm so excited to continue to do this work with you and to know that this partnership is not just for us, but it's also for our community. So for those who may not know, my name is Jay Wilson. I am the founding president and CEO of Melanated Moms. We are a community-based membership organization for moms and women across the melanated spectrum. And we focus on creating events around social impact issues that impact our communities. So this particular topic is very near and dear to the work that we do. We're very focused on maternal health, both physical, mental, and emotional. And when we had the opportunity to put this together with ACNJ, I jumped to the opportunity to make sure that we were represented well. So I'm so excited to get into this conversation. So today's conversation is called Addressing Maternal Health Inequities. And we're going to talk about how systemic racism has impacted maternal health. We're also going to speak with panelists of mothers who have had experience with having their children and some who actually had children during the pandemic. And we're also going to see the training on finding your roar and becoming an advocate for social impact issues. So we have a jam-packed agenda for you, and we hope that you are just as excited as we are to deliver it to you, okay? So first and foremost, if there are anyone who has social media, make sure that you follow all of us on our social media platforms, ACNJ, as well as Melanated Moms, across Facebook, Instagram, Twitter, and the like. We also, just a little housekeeping rules. We want this to be an interactive discussion. We have a lot of information, but we want to hear from you. So this is the time that you can utilize the chat room. Type who you are, type where you're from. We want to know if you are a parent, if you are an organization, if you're a resource. We need to hear from you. So make sure you utilize this chat all throughout the event. We have several people who will be moderating the chat rooms, the chat in the Zoom, as well as live on Facebook. So, if we don't get to you specifically, we will make sure to compile your questions and answer them later on. When you do start asking questions, we do ask you use the Q&A box if you are on the Zoom. That will help us to weed out what the questions are. But again, we do have someone that is monitoring the chat space, so we can make sure you're not missed. The Find Your Word training, as I said, that's offered through Melanated Moms, and it is a 30-minute training. After this event is over, if you are interested in receiving a certification from Melanated Moms, I need you to go to melanatedmoms.com and go to our the page that says Melanated Moms University, and just click the Contact Us and put in your information, and we will make sure to get you the certificate by this Friday. Excuse me. If you have any other questions, if you want to contribute to this conversation, again, please do so. We will have several questions throughout the event as well that we just want to ask you guys to make sure that we know who you are, where you are, and how maternal health is involved in your life, and how we can continue to be supportive to the work that you're doing and the needs that you have in your community. Okay. I'm going to share the screen here. All right. So in today's discussion, we will break this discussion up into 4 parts. The first part is going to be a historical presentation that will discuss the history of systemic racism and how it relates to maternal health and health disparities in communities of color. The second portion is going to be the panel, which will be a panel comprised of 5 women all across the melanated spectrum, sharing their experiences and how they relate to maternal health and the topic. The third portion is going to be the Find Your Word training. And then last, but definitely not least, is a call to action. Again, we want to make sure everyone is involved and interactive. So please make sure to utilize that chat space and let us know that you're here, and let us know that you want to participate. We want to continue this work, not just here today, but moving forward. The goal of this is to make sure that we're not only recognizing the past that has created these issues, but being present and saying how we can improve the lives of the mothers here in the state of New Jersey and beyond, to create a better future for the children that we have and the children that they will have, right? All right, so systemic racism and how it impacts health. Our first presenter is going to be these 2 amazing women, ROBYN Taylor and Tiffany Petitclerc. They are the dynamic duo who created Epic Health Solutions, which is an amazing organization that has done great work in health equity. And we're going to hear from them first. The revision of birth is the panel discussion with our panelists. And then part 3 is the future on how we can create advocacy and turn it into actions. All right, so the history of birth for communities of color in the United States has been historically difficult. So we're going to turn this conversation over to ROBYN Taylor of Epic Health Solutions to learn more about the history of systemic racism and maternity health. So before we do, I'm going to give her a wonderful intro, because she is amazing. Really quickly, I wanted to make sure that we had people who not only are doing the work, but represent the culture that we're talking about. But I also wanted people to know that we've already had a relationship with Epic's Health Solution, because last year, I think it was, I actually attended you guys' training, and it was so impactful. And I think there are so many things that people don't know about systemic racism and how it relates to healthcare. They also don't know that a lot of these systems are still in place, and because these have been systems that have gone on for generation and generation and generation, they don't even think of it as being something that's like an issue. It's almost like, oh, that's just common knowledge, you know? So I really appreciate the work that you both are doing to, you know, recognize what it is, and then also offer solutions in real time with people from all different backgrounds and demographics. So if no one else tells you, I want to say thank you. So yeah.
I surely appreciate that. I definitely appreciate that. Thank you so very much.
Sure. So let me give them
be here.
Of course, I'm going to give them your intro. So Epic Health Solutions is a public health consulting firm focusing on the intersection of health and social equity. Co-founded by Tiffany, I cannot say your last name, I'm sorry.
Pertiller. Yes.
Thank you. And ROBYN Taylor. Epic Health Solutions was created out of a need for more direct and authentic conversation around the ways in which society has divided itself on issues such as race, gender, class, sexual orientation, and religion. With a shared understanding of what it means to promote health and a shared responsibility to elevate equity throughout the life course, we will collectively come to the solutions that will advance the health and well-being of the most burdened populations among us, uniting us in a vision for social change in this country. So our presenter today, ROBYN Taylor, is one part of Epic Health Solutions. She is a lecturer and public servant with over 20 years of influence in schools, prisons, public health, and mental health organizations. Her love for children and communities of color drive her efforts to educate, empower, and engage grassroots organizations, businesses, and government to affect equitable policies and opportunities to be healthy and safe for all of the parts of Epic Health Solutions. They challenge the structural and systemic barriers that impede health through engagement, education, and empowerment. So I would definitely like to welcome ROBYN to the conversation. You can turn on your camera, let them see your wonderful face, and I'm gonna mute myself because this is all on you.
Okay, all right. Thank you so very much, Jay. I really appreciate you, Jay, inviting Tiffany and I to participate on the panel discussion today, and for providing a space for us to share. I really appreciate that. It is an honor to be on this Zoom call, on the webinar with all of you today. For all the folks from throughout New Jersey and those outside of New Jersey, it's a pleasure to be with you this morning. I'm grateful to be here this morning. So I just want to make sure to express my gratitude to all of you. Today is a good day. It is a good day because I'm with all of you. It is a good day because we all woke up this morning. And I hope that every single person that is on the Zoom today is doing well and taking care of yourself, because during these unprecedented times in our nation's history and in our world's history, it's very important that you are taking care of self and operationalizing your self-care. So today I have just a few minutes to share a lot of good information with you. So I'm going to go ahead and get started. So the urgency of now, you know, back in 1963, I believe it was, Dr. Martin Luther King gave his fierce urgency of now speech. And he said, we are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. This is no time for apathy or complacency. This is a time for vigorous and positive action. You know, racial equity has had a complicated trajectory. Furthermore, it is important to acknowledge how linked racism is to the customs, the policies, and practices of American society. People of color fare worse than their white counterparts in areas such as wealth, income, education, health outcomes, housing, employment, and the list goes on and on. Racialized policies and systems shape economic and social institutions. Over the years, while working with states to develop comprehensive approaches to help us all move towards equity, health equity primarily, it didn't take too long for me to realize that no matter which social determinant of health that I focused on, working with groups, working with committees, coalitions, no matter what social determinant of health that we worked on, we realized that race and racism is the greatest predictor of health in our country. Therefore, we all must work steadily to counter the root causes of bias and institutional racism, structural racism, systemic racism, in order to realize better health, better birth, and maternal outcomes. We must be intentional with addressing racial inequities and turning up the volume on infant and maternal mortality disparities. Turning up the volume. Turning up a volume is a term that was coined in Ohio back in maybe about 8 years ago, when we took a very serious and intentional effort to address the maternal and infant mortality disparities that we're experiencing here. Now, with George Floyd, Breonna Taylor, and many more unprecedented events that are happening, coupled with high unemployment and the pandemic, there is a perfect storm that is happening, so to speak. Next slide, please. So the next few slides that I want to share with you actually highlight the maternal mortality rates for New Jersey versus the United States. And you see that New Jersey's maternal mortality rate is nearly double that of the US. Next slide. So when we look at the 2019 Black maternal mortality, the US versus New Jersey, we see even more disparity here. So in New Jersey, for Black mortality, we see it's 131.8 per 100,000 live births. So, you know, there is a nearly twice the mortality rate for women in New Jersey versus the United States. Next slide, please. Now, this particular slide is very interesting to me because when you look at this slide here, it is actually showing that race actually matters when it comes to infant and maternal mortality rates. So let's look at this. So these two slides here, the infant mortality and the maternal mortality, are, we're looking at disaggregated data. And as you can see, for the specifically Black infant mortality, we see New Jersey's rate is 9.5 per 1,000 live births versus the US, which is 10.9 every 1,000 live births, right? So then when you look at the different races here, you see that there is a disparity here where New Jersey is not, it actually is doing a little bit better than the US. But then when you look at the maternal mortality rate, if you look at the Black mortality rate there, you see that for New Jersey, it's 131 deaths per 100,000 live births compared to the US rate, which is half that. So what's happening in New Jersey and why are we experiencing such a high Black maternal mortality rate? Well, I think there's a lot of different answers to that. And it goes, the answers are historical and current. So let's take a look at why this is happening. Next slide. Also, I wanted to share with you all that the urgency of now, we have to begin to address racial disparities in health outcomes, whether it be maternal, infant mortality, whether or not we're looking at coronavirus cases, or whether or not we're looking at chronic disease. We know that racial and ethnic minorities carry the burden of disease in this country. So when COVID-19 happened in our country back in March, I began to ask myself and ask my colleagues here in Ohio, Where's the disaggregated data? We're seeing all of this data all the way through April of the number of cases that were happening in Ohio and nationwide, but no one was talking about the disaggregated data. Well, my colleagues and I, my partner and I, those who work in this space to address health disparities, we knew that there was going to be some data that make people's eyes just pop open, but we were just waiting for the data to be made available. The reason why we knew that racial and ethnic minorities, specifically Black people, would carry the burden of coronavirus is because it's the same story that's been told year after year after year when we look at public health data and who is carrying the burden of disease. And there are many different factors, many different reasons why this is happening. But we're going to talk about a couple of those reasons today. Next slide. So let's take a look back in history. I want to share a couple of things with you that that historically happened a long time ago, but this still has an impact on what we're seeing today as far as educational outcomes, housing, employment, and health outcomes, just to say the least. So we know that Jim Crow laws and Jim Crow state constitutional provisions mandated the segregation of public schools, public places, public transportation, and the segregation of restrooms, restaurants, and drinking fountains between white and Black people. The Jim Crow period, which started when segregation rules, laws, and customs surfaced around the Reconstruction era, ended in the 1870s, but it existed until the 1960s when the struggle for civil rights in the United States gained national attention. Were there Jim Crow laws in New Jersey? Well, imagine visiting Atlantic City and being barred from your beach of choice, or being told to stay off the Asbury Park boardwalk until after 10:30 p.m. From the 19th century all the way until the 1960s, African Americans in New Jersey regularly faced such Jim Crow treatment. Author David E. Goldberg documents the era in the Retreats of Reconstruction, Race, Leisure, and the Politics of Segregation at the New Jersey Shore from 1865 to 1920. A history professor at Drury University in Missouri, Goldberg says the shore was an economic and social laboratory for civil rights after slavery ended. Next slide. So some of the things that happen historically, and one of the areas that I like to talk about is the housing policies that help to shape the communities and neighborhoods that we see today all across the United States. So I want to start with talking about housing and what happened with housing. Now, one of my favorite books, Richard Rothstein wrote, which is The Color of Law, The Forgotten History of How Government Segregated America, chronicles the role that government agencies, including the Federal Housing Administration and Internal Revenue Service, had in the creation and reinforcement of segregation across this nation. Federal Housing Administration policies defined neighborhoods, in particular Black neighborhoods, as undesirable and ineligible for mortgage insurance, for example. This is a practice that was known as redlining. And the map that you see here on the screen is a map that I was able to find, an historical map of Newark, New Jersey, and the redlining that took place there and how they separated the areas of the city. Simultaneously, the agency provided funding to develop housing for white residents, predicated on the restriction that no African American residents would be allowed in. As a result, massive numbers of white residents were able to buy homes, whereas African Americans were not able to buy homes and build generational wealth. Neighborhoods across the nation were racially segregated, and some remain segregated to this day. Tax policy has historically reinforced discriminatory policies in multiple ways. So, for example, deductions for home ownership are incentives that disproportionately benefit whites, making it more likely that they will own homes than people of color. Newark was not the only New Jersey city to suffer from these practices. Jersey City, Camden, and Trenton also saw their total populations decline as whites moved out and Blacks and eventually Hispanics moved in. The Federal Homeowners Loan Corporation rated Newark neighborhoods. The 1939 Newark area residential security map did not designate a single neighborhood in that city of more than 400,000 as worth of an A rating. High-class Jewish sections like Wakakik and Clinton Hill, as known as non-Jewish areas like Dallasburg and Forest Hill, all received the second grade, or a grade of B. Typical Newark neighborhoods were rated even lower. The well-maintained and attractive working class sections of Roseville, Woodside, and East Dallasburg were given third grade or C ratings, and the remainder of the city, including Immigrant Ironbound and every Black neighborhood, was written off as fourth grade or hazardous. Real estate blockbusters drove whites out of the city by playing up fears some had of racial integration. So there are stories of these different real estate agents actually having a Black woman with a baby carriage walk down the street of a white neighborhood to scare the neighbors and say, see, Black people are moving in, you need to move out, you need to move to the suburbs. And these are things that were systemically happening in our past, in our nation's history. On this slide here, not only did we have racial zoning that was happening all across the country, we also had a thing called racial zoning ordinances. And the first ordinance happened in 1910 in Baltimore with Mayor Warhol. And Mayor Warhol actually used public health as a reason to segregate or separate Blacks from whites. He said Blacks should be quarantined in isolated slums in order to reduce the incidence of civil disturbance, to prevent the spread of communicable disease into the nearby white neighborhoods, and to protect property values among the white majority. And as you can see here, what's on the right in this circle is showing that this trend began in Baltimore, but it began to move across the nation as folks looked to Baltimore and their example of how they were able to segregate whites and Blacks. And so we began to see many different cities across the nation begin to also apply racial zoning ordinance throughout the United States. Next slide, please. Along with redlining that was developed and maintained by the Homeowners Loan Corporation, we also had the zoning, as you see, but we also had racial land covenants as well. So before 1948, these covenants were legally used for segregationist purposes. The purpose of an exclusionary covenant was to prohibit a buyer of property from reselling, leasing, or transferring the property to members of a given race, ethnic origin, and/or religion as specified in the title deed. This is critically important because as development began to happen in the suburbs in the US, we had these racial land covenants that were attached to them. Some of them even were so specific to say that this division shall be used or should be used or occupied by anyone who is not of the Caucasian race, except when they are servants or domestic positions in the household, such as a butler or a maid or something of that nature. So these were things that dictated where people could live. And amazingly enough, it's amazing to know that these land covenants are still attached to homes today. And as a follower of Richard Rothstein's work, the author of The Color of Law, one of the things that we have developed is a statement that folks can actually sign to denounce the racial land covenant that they may find that is still attached to their home or their mortgage. Next slide. Also in our nation's history, which caused this segregation and caused some to have opportunity and some not to have opportunity, was urban renewal. And urban renewal is a program of land redevelopment often used to address urban decay in cities. Urban renewal is the clearing out of blighted areas in inner cities to clear out slums and create opportunities for higher class housing, businesses, and more. A primary purpose of urban renewal is to restore economic viability to a given area by attracting external, private, and public investment, and by encouraging business startups and survival. The problem with this is that when this was happening in our country back in the 1950s and 1960s, the communities that were blighted were mostly communities of color. Urban renewal policies were used to demolish areas known as slums, what they call slum areas, in order to redevelop the land. And in the process, neighborhoods of color were demolished, people were displaced, communities were fragmented. And the crazy part about it is when folks were pushed out of their homes, there wasn't enough housing to respond to the demand of housing. Once people were moved out of those areas, they were pushed into even more crowded areas, which was what they were trying to avoid in the first place. But it had a different impact for people of color. Also, the reason why I put this highway picture here on this slide is because even with the Highway Infrastructure Act that our country had in place in the 20th century, in response to the many automobiles because of Ford and Chevrolet and the booming American automobile industry, we had to look at the infrastructure of how people were getting around in our cities. Well, when we began to develop our highways here in America, guess where where those highways were placed? Normally, those highways were built directly through Black neighborhoods. And when that happened, again, you had families of color that were displaced without enough housing for people to go to. And this is a part of our American history. I encourage you to look at your city's history. This information is available to you in the archives. You can definitely read and see which neighborhoods were demolished in order to promote urban renewal or to develop highways that we use every day today. Next slide. So these are all the federal policies that, when looking at housing policy, historical housing policies that influence the neighborhoods that we see today. Again, we talked about the Federal Highway Act of 1953, urban renewal, the FHA, and the creation of the Standard Mortgage and the Homeowners Loan Corporation. But also there was the dismantling of the streetcar system, which, and then the high-rise public housing. But let me talk a little bit about the dismantling of the streetcar system. When white flight began to happen across our country, as white people began to move into the suburbs, at that time, the public transportation that was very common at the time was the streetcars. Right. So as the white flight began to happen, they began to dismantle the streetcars, or the streetcars did not travel further out to the suburbs. The problem with that is that when white flight happened, and folks began to move to the suburbs, the jobs were moving to the suburbs as well. And so if people that were in the inner city did not have a way to be able to access those jobs or get to those jobs, they were left out of the opportunity to be able to have those good paying jobs that had moved out into the suburbs. We also had the GI Bill of 1944, which was supposed to be a good thing, right? And there are some really good tenets and facets of the GI Bill. However, back in 1944, when after World War I and World War II, and even after Vietnam War, when the soldiers were coming home and wanting to purchase land or purchase a home, most of the white soldiers were able to do that, to take advantage of that benefit. However, Black soldiers were not, due to land covenants, racial zoning, the redlining of neighborhoods and cities in our nation. They were not able to buy homes in areas that they would want to buy homes, and if they did find a home in the inner city in a Black neighborhood, they were given a very hard time with getting a mortgage because of the redlining, the red category for their neighborhood. If they were able to get a mortgage, the mortgage was at a very high rate, which is very different. So the soldiers were left out of that particular provision of the GI Bill. However, African-American soldiers began to take advantage of the educational opportunities of the GI Bill instead of the housing benefit. What's important about Berman versus Parker in 1954 in the DC area, Berman, they were business owners, Black business owners, and DC, Washington said, we want to take this this land that you have, this building that you have, we're going to demolish it in the name of urban renewal. Those business owners, those two Black guys, decided that they were going to fight this in court. They took it to court, took it all the way to the Supreme Court, and it was declared that the city could, that eminent domain was constitutional. And so what's really important about this case, Berman versus Parker, is that eminent domain has been used throughout our history to do that very thing, to take communities, to take housing from Black communities in the name of the public good. I'll give you an example in Detroit, Michigan, where the Ford plant sits today. Before that Ford plant was there, that particular area was a thriving African-American community with successful businesses, schools, banks, churches. Everything that was needed was there. But Ford approached city council and said, you know, we want this land, we want to build a huge plant here, and we are going to pay, you know, tax money is going to come to the city, jobs is going to come to the city. The city obliged Ford, and they were able to destroy hundreds of thousands of homes and displace hundreds of thousands of African Americans that had to find new places to live. Next slide, please.
So I know this is all like incredibly amazing information, and it's actually kind of jarring to me because I feel that I've seen how redlining has impacted my own life and the way that I've grown up in the neighborhoods that I grew up in. And I remember having conversations with my grandmother about white flight and how she moved into a middle upper class neighborhood. I'm originally from Buffalo, New York, and she said her and maybe another neighbor of ours was like the first African American families on the block, and within 2 years it was a completely different neighborhood. So I know that we're gonna start talking about allostatic load, but I'm just making sure that we're staying on time. Can you talk about how allostatic load relates to white flight and how it impacts our, you know, the different stresses that people have?
Sure, yeah, definitely. So, you know, this slide here talks about the life course, right? So just think about from birth to when we become older adults, you know, all the different experiences that we have from birth through the course of our life. And just think about it from the perspective of here in the United States. I gave you one example of one industry, which is housing. But if we begin to analyze all of the policies as it relates to education, transportation, employment, higher education, we will see a similar story for all of those industries. So just imagine knowing that when I go to school, or if I want to get this job, or if I want to buy a house, that I have additional things that I have to do, or I have to prove myself even more so, or just the different experiences we have over the course of our lives. So when we begin to talk about allostatic load, I want to tell you what that is. That is just the impact of stress over time. So the impact of structural racism can be felt over the life course as we thrust into a society with systems and structures that benefit some over others. This can cause an allostatic load of stress for some. Allostatic load is defined as the cost of chronic exposure to elevated or fluctuating endocrine or neural responses resulting from chronic or repeated challenges that the individual experiences as stressful. There are many researchers that have really examined and explored the impact of allostatic load on birth outcomes for African Americans, just for women in general, really, but also for African Americans. You know, what happens to the body? Do we store those messages in our body, and are they transferred to our babies in vitro? What happens? So recent studies show that racism influences our health. As individuals grow from infancy into old age, they encounter social institutions that may create new exposures to racial bias. Many studies have investigated the relationship between discrimination and health. For the most part, these studies suggest that discrimination is related to illness. Yet, major questions remain as to how experiences of discrimination may vary across the life course, whether discrimination at specific developmental periods may vary across the life course or may be harmful than others at different ages, and how these experiences accumulate over time. So a life course perspective provides a key way to integrate a large body of research on discrimination and health. It highlights the connection between individuals and social institutions and suggests that efforts to eliminate inequities require considering how racism may not only create adverse exposures, but also structure time.
Wow.
Next slide.
That's amazing information. So I'm just taking all of this stuff in, and even from the first time we met, I was blown away. I feel like it's coming all back to me again. So we've covered all this history, and we've seen how it has impacted us from 50 plus years ago. Can we talk about, just really quickly, how Epic Health Solutions has contributed to changing these narratives, us here in New Jersey?
Yes. Tiffany and I were very, very fortunate to meet a woman that was able to, talk with us, and she had actually participated in one of our sessions in St. Louis, Missouri. We were at our Chronic Disease Academy for the National Association of Chronic Disease Directors, and she came and she talked to us, and she said, you know what, I'm really interested in having you all come to the New Jersey Department of Health and providing the same training, but specific to New Jersey. And Tiffany and I were able to do that. And so we have been involved we actually did a training tour, a health equity training tour in New Jersey. I believe we have provided over 10 or 11 trainings in the state of New Jersey, in Trenton and Camden, and also in Newark. Currently, our work continues in the state of New Jersey. We are currently partnering with the Nicholson Foundation as well as the New Jersey Department of Health to develop health equity community champions or trainers. So we are actually, next week, we are actually developing 15 New Jersey community members to become health equity community trainers. We have developed this train-the-trainer program that is called Reach One, because we believe each person can reach at least one person to raise awareness and turn up the volume on infant and maternal mortality in New Jersey. So we're continuing our work. We're very engaged with the state of New Jersey. We are very happy with the work that we have done. We've met some amazing champions in New Jersey that are carrying the mantle and raising the volume and helping people to understand what is happening with what is happening with maternal and infant mortality in the state of New Jersey.
This is incredible. I'm so grateful that you and Tiffany both have dedicated your work and just your background into finding ways to learn from our past so that we can create a better future. I want to thank you so much for being a part of this and for helping us set the stage for this type of discussion. And I don't want
so much.
No, thank you. I don't want to stop today. Like the work that we're doing here, we have to do it in partnership. And to know that you both are so dedicated and you've been working with New Jersey on improving our outcomes, and you're doing it throughout the country as well. Like, we're so honored and blessed to have you as a part of this. So thank you so much.
Thank you.
So moving forward, everyone, I hope you all were able to take that in. That was a lot, but it was great information. I know ROBYN is gonna be leaving us, but we will still have Tiffany on, who will be answering questions at the end of our panel. So if you have any particular questions related to the history of systemic racism, I'm asking you to please put it in the QA box. And after we finish our panel, you will have the opportunity to have your question answered. Okay, so we're gonna move on. Thank you so much.
Thank you. Bye-bye.
So bye. So we're gonna move on into the present. So the goal of this conversation is to learn from the past and learn about, you know, how systemic racism has set up this these maternal health and health disparities in communities of color. But we want to create an improvement system to create a better future for our moms here in New Jersey and beyond. We're now going to hear from our panel of mothers to discuss the current state of pregnancy through this pandemic. So I'm so excited to bring you guys these 5 amazing women. I'm very honored to say I know them all personally and professionally. I believe in the work that they do, and they're all mothers as well. So I'm going to start with Mrs. Abby Scher. Abby is the owner and founder of BU Decor, where she creates customized interior and event designs that fit your vision and your budget. She obtained her BS in Family and Human Services, and she has challenged herself to use her education during this current pandemic right now through her current pregnancy. So she has the wonderful blessing of being pregnant with her 2nd child right now. So I want to welcome Abby to the screen. Come on out. Our second panelist. Uh-oh. Did it stop sharing? Sorry there. Our second panelist is Shayna Davis. Shayna is a holistic wellness enthusiast, wife, mom, and soon to be mom of 3, because she is also currently pregnant. She's also a full spectrum doula and mommy advocate. Maternal wellness and rights have always been a part of her life, especially after the birth of her first son in 2012. Being pregnant right now has been a very humbling experience, and we can't wait to hear more about her work as a doula and advocate. She actually, we'll get into it later, but she actually was one of the doulas for one of our panelists. So we're actually going to have a segment where we're going to ask them how that relationship was at the height of COVID. So let me definitely welcome Shayna Davis. Say hi, Shayna. Moving on, I'm going to welcome Mrs. Nadia Hussein. Nadia is a maternal justice campaign director with the nonprofit organization Moms Rising. She works to encompass maternal health, mass incarceration reform, and police reform work. And she also serves as a board member for the ACLU, as the board of trustees for the state of New Jersey. She also co-founded the nonprofit organization BALTIMORE, which stands for Bangladeshi American Women's Development Initiative. And they work to create community initiatives to empower Bangladeshi women and girls in the state of New Jersey. She is the mom of 2 young boys, and her latest addition, cute little Emiliano, was actually born at the very beginning of the pandemic in March. So I want to thank you so much, Nadia. Say hello to everyone. Next, we have Dr. Yetunde Orefia. She is a board certified hospital-based pediatrician with over 11 years of experience. She is also a fellow of the American Academy of Pediatrics, and she has a special interest in newborn and breastfeeding medicine. She is an advocate in regards to finding ways to mitigate maternal and newborn health care disparities in the hospital setting for communities of color and beyond. Thank you so much for joining us, Dr. Yetunde. Hello. And last but absolutely not least, we have Ashley Watson. She is a community health worker with the Central Jersey Family Consortia on the Healthy Women, Healthy Families grant, which is led through the Nurture New Jersey project of the First Lady of New Jersey. Ashley has been working as a CHW for over 2 years with experience with working on the Improving Pregnancy Outcomes grant, which was the grant previous to Healthy Women, Healthy Families, that is led by the Department of Health in New Jersey. She is passionate about helping other women through the phases of pregnancy and birthing, and to also become and to continue to be a resource when they need her the most. Thank you so much, Ashley, for joining us. I'm so excited to get into this. So my first question is actually for the full panel. So I want to ask you all, there's my rising page. Okay. I don't know why this keeps cutting off. Sorry, guys.
It's actually Catherine from AC&J. I'm actually sharing so that way we could show the full panel.
Oh, okay. Sorry. Sorry about that, everyone. So my first question is going to be, how have you seen maternal health change during this pandemic? And if we can start with Abby.
Hi, everyone. I can say based on personal experience, I won't try to speak for everyone, but I think I wouldn't say they've gotten a little lax, but since this is kind of unprecedented during our livelihood, I guess certain protocols weren't really in place, or they haven't tried them yet, and so it's right now that they're trying them. And so I've gone a few months actually, and I'm pretty far along with no one having called me and set up an appointment. So when I called myself, I'm like, you guys usually say, we're going to call you, don't call us, we call you, we set up the appointments. And I called myself and they were so shocked. They were like, oh my God, are you sure? And I'm like, you see the last time I've been in the office. So they were so apologetic, and it's really, something you have to be understanding about, but it's definitely, you have to set up a lot of stuff. Like, things are not the way they were. You have to set a lot of stuff up yourself, even though they tell you, no, we got this. Like, it's not their fault, but they don't.
Okay. Dr. Yatende? Same question. We can't hear you, you're on mute. There you go.
Good morning, everyone. The way I think things have changed in regards to the pandemic from a healthcare standpoint is the fact that we now not only have to worry about, giving great clinical care, but we have to also worry about protecting our patients as well as ourselves, because I think this pandemic has shown is that no one is immune to this virus. And even though we had thought we had protected groups such as children, we are now learning that that's not the case. So if anything, what I've learned is that in this time, one has to be flexible. One has to be able to change with what's happening, as well as just really draw back on our inner strength and our inner strength to get through these tough times.
Awesome. And Ashley?
Yes, good morning, everybody. As far as maternal health change during the pandemic, I had a couple of clients that explained to me they're now, scared to go to the emergency room. They've been delivering their babies alone. Visitors are limited. So it's just that uncertainty. Also, if you are diagnosed with COVID, that temporary separation from mom to baby. So the uncertainty, definitely.
Nadia, same question.
Yes, so good morning, everybody. With Moms Rising, one of the things that we've been working on is also what's happening around the country systemically. There's the personal experience, but there's also what are the protocols? What is the CDC putting out? Again, this, as prior panelists have said, this is completely unprecedented, and our healthcare system already came in with so many issues, right, when it came to maternal health. But for example, what the CDC's guideline was in terms of allowing a doula in, things like that, birth support, should the person giving birth be alone, separating, not allowing breastfeeding, it was all over the place. Actually, the CDC's recommendations went COVID really broke out in the United States, was not the same as the World Health Organization. So even hospitals and doctors and nurses and midwives and doulas were getting conflicted information in terms of just policy and hospital protocol. I know that one of the things that Moms Rising has been doing, and I know not just Moms Rising, but a lot of national organizations, Black women-led organizations, is advising the CDC and saying you cannot be separating babies from the mom, that breastfeeding is essential and it's healthy and it helps the mother and it helps the baby. But you know, luckily the protocols have been updated in April 8th. However, as we know, sometimes hospitals might not be getting the most updated information. Maybe providers might not be getting the most updated information. So it is essential for sure that folks advocate for themselves. But I also say for advocates who are out there doing this work, it's a hard time, but we also need to be available for the mothers, because it's so scary to be there by yourself or to get the wrong information and not know what the right information is. So advocates also need to really ensure that we're stepping up, right, and standing up for the people giving birth in these places, in these hospitals, and in these different places, and giving the proper advice, and us knowing and being abreast of what the protocols are and what the rights are.
Awesome. And last but definitely not least, Shayna.
Hello, everyone. So definitely as a doula and as a mom going through this right now, as you stated, I'm pregnant with my third child. I do see that it's a lot of back and forth and a lot of misinformation. Everybody wants to be informed, but there's so much information out there that they don't know, you know, what to take in, what to say is the correct protocol now or not. I too have to call my doctor's offices and say like, hey, when am I coming in? Is it time for a check? And they are like, oh yeah, it's just, you know, dads can't come this time if you're okay with that. Okay, yeah, sure. You know, ultimately you want the health of your baby, and they want the health of themselves. So it's a difficult time and it is very scattered, but I think now as time has progressed, it's becoming more stable. And I'm hoping that, you know, what month are we in? We're in like the 6th month of this happening. Hopefully we can now get it together.
I think that's really, really important to really talk about, because there may be other women who don't feel empowered enough to lead, to be a leader in their care because they're used to the medical providers or, you know, their medical team keeping them on task, you know. So I think it's important that you both shared as pregnant women and you know, as women who have given birth during this current pandemic, to advocate for yourself and calling your medical provider and telling them, hey, you haven't seen me. I need to be a part of this healthcare issue, you know, or not issue, but you know, a part of this healthcare team to make sure me and my baby are having the safest delivery possible. So I appreciate you all for sharing that portion. So I'm going to ask an individual question now. We're going to ask Ashley. Hold on a second. Everything's freezing. Ashley. Thank you. All right, so my first question is for Ashley. You work for the Central Jersey Family Consortia, and you have a very unique role. You are a community health worker, and I don't think a lot of people know how valuable a CHW really is, especially to moms in need. So if you can, just give us a little insight on what a community health worker is and how you've used your position to support other mothers that are currently pregnant right now in this pandemic.
Okay, not a problem at all. Yes, I am a community health worker for Central Jersey Family Health Consortia under the Healthy Woman, Healthy Family Grant. I do serve Middlesex and Somerset counties. So basically what we do, we are trusted members of the community. We serve as a liaison between health and social services to facilitate access to services and improve the quality of that community. We are dedicated individuals. We promote community empowerment. We also serve women of childbearing age 15 to 44, as well as their families. We give them access to resources and referrals in the community. Last week, I had 2 clients that needed diapers and wipes. So what I did was I contacted the diaper bank, and I put in a referral for them, and they were able to pick up the items that they did need. We also assist with local food banks in the area, WIC applications. We give them housing information, amongst many, many more. We provide clients also with intensive case management and support, face-to-face assistance and follow-up, and education as well on the 4 stages of life. You have preconception, which is before she becomes pregnant. Interconception is that in between, and that is she already had a child but is not currently pregnant. Prenatal, of course, you ladies being pregnant, and postnatal health, which is after childbirth. We also complete comprehensive assessments every 6, 12, and 18 months. So we are there for the support of the mother and the families.
Thank you. That's so important because we have moms who don't know how to ask for help, or don't know that there is help that is available for them. And they may associate it with socioeconomic status, but what I really like about the Healthy Women, Healthy Families Project is it is not only for, poor, disadvantaged women. You touch women from all walks of life. If they call and they say they need help, they need a resource, you guys provide that. So I think that's a very unique thing. It's also important to know that you can ask for help if you're outside of, the socioeconomic bubble of, help. And with CHWs, you also mentioned that you are a trusted member of the community. That is key. In different communities of color, it's often seen that people who don't look like them try to come into their communities and build relationships without understanding that authenticity is actually what leads the trust factor. So people need to know how to identify with a person that they're going to trust. So I really commend you for not only being a part of the community, but also, being that trusted member and helping women to improve their outcomes. Thank you so much.
Thank you.
Yeah.
And the second question you asked, how have we been helping mothers throughout their pregnancy? As you know, we've been working remotely since March, I'm sure like most of us. I have been in constant contact with my clients, whether it is a phone call, an email, a text message. I do make sure I reach out to them. I've been helping them, be that listening ear, because some of them are in isolation due to COVID. They have no transportation. They just want to vent and get their points across, and I'm there to listen. A great resource with material. We actually do a county update every week for the different counties. So we do send that out to our clients, and we also put that on our website. Also, I've been helpful and supportive. I check in on them, check in on the kids, make sure they don't need anything. If they do, I definitely send that out. And also helping them to gain confidence and strength to be more independent on their own. And we have some CHWs, including myself, that actually went above and beyond and actually delivered safe sleep cribs during the pandemic. We just want to make sure, the children and mothers and everyone is safe. So.
Awesome.
Thank you.
Thank you. No, thank you. All right. So our next segment, we're going to actually talk to Nadia and Shayna about their experience with delivering during the pandemic. So at the height of the pandemic, we had Nadia, who was pregnant with her beautiful little boy, Emiliano. And when she went to deliver, she actually was met with a different, perspective of support, because the hospital had to change a lot of their parameters around support because at the time, COVID was very new. No one knew how to really react or, what to really do. So, they took a lot of safety precautions. But in the midst of taking those safety precautions, they also, unfortunately, would not let Shayna, who was her doula, to come to be a part of her support system during her delivery of her son. So I really wanted to know, first, Shayna, if you can help us just have a little history about, or just define for us what a doula is. And then Nadia, I just want to get your feedback on how you felt delivering without your doula that you had planned to utilize during your pregnancy or during your delivery.
Okay, so quite simply, a doula is a trained birth coach. We're there to help mom through her delivery, help to keep her informed of her options, be a support, of course, physically and mentally, because we help to ease a lot of anxiety surrounding birth, as well as just keeping her informed, as well as dad. So doula is a birth companion. Nothing too extravagant, but definitely plays a big role and has been proven to reduce medical intervention in the birthplace. So that's a doula.
Thank you. And Nadia, tell us how you felt, having to change your birthing plan in the midst of the pandemic.
I mean, I had to change it even right before. I always wanted my mother to be there with me because she was there for my first birth, and I just felt like I just couldn't. I almost felt like I couldn't give birth unless my mom was there to be my support system. And a week before, the OBGYN were like, "We're sorry, even though it was like I didn't know if my husband could come or my doula, and they knew I wanted both, but they were like, oh, husband or doula, and I'm just like, that's a crazy choice, but." I think I don't blame the OBGYNs either or the hospital. I think they were scrambling, trying to figure out what was right or wrong, or what was recommended. And, and then the day I called them, and the day, I think on Friday, they were like, yes, you can have a doula. But he needs to be certified, just have a certain certification, which is, before I had a doula, was a trainee doula at my first birth, and that they were just like, sure, she was just there, my mom was there, I had a bunch of people with me at birth, even in a hospital, but and Shayna knew that, she hadn't worked at that hospital, but she had given birth, help with births at different hospitals. And I actually gave birth a week early. So I was due March 20th, but I gave birth March 15th. So everything was kind of rushing in, to give birth. And my contractions were actually happening super fast. So if you're asking how I was feeling, like I was feeling anxiety, mostly because I knew my mom couldn't be there. And I didn't know what was happening. Things were changing so fast, and I was giving birth a week earlier than I expected. And so as I was in the hospital, Shayna was on her way, and the contractions were just coming. I dilated like from 5 to 8 or 11 centimeters in an hour, which is a lot. Like it's really intense contractions. So frankly, I didn't have time to feel a lot because I was just in so much pain, just trying to breathe through these crazy contractions that were coming back to back to back, right? As my cervix, as everything was opening for this baby. And unfortunately, we did think the doula could come, and Shayna could be there, and she was there. But at the last minute, they were just like, oh, we need this kind of certification from, I think, and we know this with doulas, right? Like there is certifications, but there's no like official, like, oh, this is a medical doula, or, it's not like nurses or doctors that, oh, I went to medical, it's just not there. And so even though Shayna had a certain certification, that wasn't the one they wanted. And so she actually came, and she was in scrubs, and she was ready, and she was there like rubbing my back, and they were like, you have to leave. And I just honestly didn't have time to be upset, I just was just in the throes of labor, and the epidural hadn't kicked in yet. So, I felt bad for Shayna. I felt like, she had given her time and come out, and she was excited to be there for my birth, right? And so I felt bad that she had to leave. And they weren't, yeah, so that sucked, frankly. But again, and she was able to get another wonderful doula to try to cover Chantel, who had that certain certification. But actually the baby came out already. Once Chantel got there, like an hour later, the baby was out and smiling. And I will say a couple things that I was lucky. I was healthy. I didn't have pre-existing conditions. No, my birth did happen in a healthy way. The baby just happened to come super fast. And the fact that it came super fast, baby was healthy, I was healthy, it was like there weren't complications, and so boom, it just happened. I also did not have prior trauma with a hospital setting. I was comfortable in a hospital setting. I was still nervous because of COVID, but I was still comfortable. So I do want to outlay those factors of, you could say privilege, you could say advantages or that I had going into the situation. So it turned out okay. I didn't personally, I guess I didn't blame the hospital or anybody, only because I just realized everybody was on high alert. Everybody was stressed out. It was just such a strange situation going into a pandemic. But that was my experience. It wasn't ideal. I would have loved to have had Shayna, you know, be there for the baby, see the baby. I think this is the first time she's actually saw the baby on the video outside of pictures. But yeah, it's I don't envy mothers giving birth right now. I don't envy doctors. I don't envy doulas. It's a really crazy time.
Yeah. Thank you. Thank you so much. So I want to make sure that we're staying authentic to the work that we're doing. And I wanted to make sure that we heard the story and we continue to hear these stories of women who have been birthing during this pandemic. So I really appreciate you sharing that, Nadia. I know it was a very personal experience, but it's also very scary, right? But it felt good to hear that Shayna definitely was there. She was still there as your support. And you were still able to get even a backup doula. And Chantel is an amazing doula as well. So I'm glad that you were able to share that. So I'm going to move on to actually our doctor, Dr. Yatende, who is an inpatient pediatrician. And she interacts with a new mother, you know, so she actually gets to see the transition of the journey from woman to mother. And I really would love to hear her insight on how she has been able to support moms right after they've given birth. So if you can just share with us, how has COVID changed your interactions with your patients? And how have you been able to support moms who want to breastfeed right now with COVID happening?
Okay. Well, good morning again, everyone. And first off, I would just like to say again, thank you to Jay Wilson of Melanated Moms for inviting me to be a part of this panel, and also for Advocates of Children of New Jersey for hosting this very needed event. To briefly describe my background again, I am a board-certified pediatrician with a special focus on newborn medicine. So essentially, I've spent the past 11 years of my career serving many hospitals and communities throughout the state of New Jersey. In all these years of practicing pediatrics, I can honestly say I've never seen a time like this before, and there's absolutely no denying the intersectionality of an unprecedented global pandemic, as well as the healthcare disparities that have existed for a very long time. But now we are starting to really see that this is an issue, and it's starting to receive the attention that it deserves. In New Jersey, a lot has changed since our onset of the knowledge of the virus since February. Back then, the medical community was aware of the existence of the virus, but the peak didn't really start to overwhelm the New Jersey hospital system, I would say, until about late March, early April. When this did occur, the CDC had set up many guidelines, including PPE use, that was constantly evolving based on the new information that we were discovering daily in regards to this virus. This resulted in many multiple daily debriefings in regards to where we were at. Examples of this were ICU bed status, the number of COVID admissions coming through the ER, how many ventilators were used in the hospital, how many ventilators are needed in the hospital, and unfortunately also the number of COVID fatalities. As some of you may know, actually, New York Presbyterian Hospital was one of the first hospitals to have to make major drastic changes to their mother-baby policy to not allow any visitors. This included doulas, this included fathers of the babies, husbands. They were not allowed to have any family members. This is because this hospital was at the epicenter of the outbreak, and the virus was spreading so fast that they could not take a risk. As a mother myself, I couldn't imagine what it must have felt like for a mother to have to go in labor, knowing that she would have to, besides the hospital staff, be alone, meaning no family members, no support system. as a result of this, there was a lot of outcry because mothers who felt like they couldn't get the support system felt, you know what, I think I may just have to leave the state. And it did show that, you know, a lot of planned admissions were actually canceled because women were leaving the state, they were leaving the area, even some heading over to New Jersey to start to receive their care. And as you know, as a mother who's about to give birth and you're followed by one physician throughout your entire pregnancy, and you're going to a new facility where they don't really know you and they might not have access to your medical records, it can cause, you know, it can necessarily cause a host of issues, which can be problematic. On the other hand, in New Jersey, although visitor regulations never became that restrained, there was definitely still a marked difference in the ability for mothers to have all their support people in the delivery room. The facilities I've had a privilege to work for, those are considered baby friendly. And I don't know who's familiar with that, but Baby Friendly is actually a hospital initiative. It was actually launched in 1991. And this was an effort between UNICEF as well as the World Health Organization to ensure that all maternity units, whether freestanding or in a hospital, became centers of breastfeeding support. And the reason why this is important is because years ago, after a mother delivered her baby, typically soon after birth, nurses would usually take the baby into the nursery, administer necessary medications, many times give the baby a bath, do vital signs. This process may take up to an hour or two. So that vital time for skin-to-skin contact, kangaroo care, bonding between the mom and the infant didn't have a chance to happen. So this is why things started to go in the direction of being baby friendly. Now that we do know the importance of maternal and infant bonding in the first few hours of life. And although I cannot speak for every physician in every hospital, and I'm not currently in the inpatient setting, I am proud to say that although major changes have been made, there has been no increase in poor maternal infant outcomes due to the pandemic in the settings that I have had my experiences in. And the reason why I say this is because I want to make sure to alleviate some of the fears that many women do have entering the clinical setting for delivery. There has been an increase in number of mothers who are deciding to deliver at home. And while some mothers are candidates for this, meaning low risk pregnancy, did receive care under a midwife or a physician. In the wrong setting, a mother who decides to deliver at home could put herself in a very dangerous situation. And so what I would urge everyone is to make sure, you know, you're under the guidance of a medical professional during your pregnancy. Don't be so afraid of what you're seeing in the news to prevent you from seeking care when you really need it. What I would say is, although no poor outcomes have been identified in my personal experience, there has been a major psychological component that I do feel is very difficult to quantify. And for example, moms who didn't get a chance to have visitors, that's you know, something that can be a lasting experience, feeling alone and not having to get those pictures and those memories to carry with you for the rest of your life. That can follow a mother. Other examples were when we didn't know as much as we do now about COVID. There were times where babies were separated from mothers, babies were placed in isolates, and unfortunately there were times where, you know, there would be have to go for observation outside of the mother's room. We now know that, you know, based on new guidelines, that mothers can stay with babies after birth and they can bond, even if they are a person under investigation for COVID, and even if they are a known positive. Of course, we always have to think of the health and that mother and infant first. We also have to weigh the known impact and importance of skin-to-skin bonding, as well as early kangaroo care. I would like to reiterate, based on the latest WHO guidelines, COVID is not a contraindication to breastfeeding. And what I will say is that we cannot say with evidence yet whether COVID is transmitted through the breast milk or whether it is not. But with the evidence that we do have, we do know that the benefits of breastfeeding outweigh the risk of transmission of disease. The reason why is because Mother's breast milk has lots and lots of antibodies, including one specific one called IgA, and that is responsible for protecting the infant against many, many diseases, respiratory diseases, diarrheal illness. So the advantages of having that protection outweighs the risk of, in the future, could we possibly find out if this milk can transmit COVID? If we do, then the guidelines would have to change. One thing I would also say about breastfeeding is when you're in the hospital, please do not hesitate to ask for assistance. It may feel a little bit more impersonal now. Your provider may be gowned, gloved, masked. I know that may feel impersonal, but at the end of the day, it's for your protection. It's for your infant's protection. And this is just for all of our safety. With this said, I also want to make sure that I emphasize the importance of health literacy, being your own advocate. I know for me, when I had my son, my physician, obstetrician, even knowing I was a physician, gave me tons and tons of handouts and literature. He had lots of handouts in the office. I would always make sure to pick up all the handouts and read them from top to bottom, not missing a single line on a single page. I urge you to not just listen at the visit, take something home written. I really do recommend that you use sources that your provider and your doctor is giving you and not doing a Google search, because unfortunately, we cannot screen all of the information that is online, and unfortunately, there is a lot of misinformation being put out there. So the most important reference you need is to have, number one, a trusted relationship with your physician, and making sure that you stay informed with all of your visits. Ask the right questions. Don't be afraid. There is no such thing as a stupid or dumb question. I hear that a lot, and there is no such thing. Don't be afraid to ask if you're not sure about something and you want to know why a certain test is being done or something is happening. Another thing is, if you feel like your provider is not a good fit, don't feel a sense of loyalty. You make sure that you seek care elsewhere. Find someone that you're going to have a good fit with. Find someone who makes you comfortable. Find someone who's answering your questions in a timely manner. Find someone who's going to get you in the office in a timely manner. If you're getting pushback and you don't feel like you're getting the care you deserve, you have a right to seek outside care. Another thing is, make sure you're utilizing your support system. I know we're in a time where there is social distancing, but that does not mean that you cannot use your support system virtually. Many hospital systems have breastfeeding groups, and they do typically meet in person, but now because of COVID, a lot of times they're having to move to a virtual setting, such as Zoom. Take a part of that. That tends to be very helpful. Please make sure that you're getting outside in a safe way. Open air, fresh air, that helps to increase your vitamin D. And studies have shown that that does help in reducing postpartum depression. And, as a mother myself, postpartum hormone changes are a real thing. And the birthing experience is just the beginning. So just please, utilize that support system that you have. And with, just making sure to take care of yourself, take care of your child, and utilize your community that you have. And with that, I think we are all, get through this together, and we'll see the other side of things.
Wow, thank you so much. All of this information is so valuable. Everyone, all of you all have just given so many amazing gems, not only in terms of your profession and your dedication to it, but also from your perspective as mothers yourselves. I want to just thank you for being able.
Thank you so much for having me.
Of course. I wouldn't have it any other way. I love that in everyone's responses, you not only talk about your experience, but you also encourage others to advocate for themselves, and with that, I do want to segue into our upcoming training. But in the interest of time, I do want to do two things. One, I want to thank all of our panelists for being a part of this discussion, and for being the advocates that we need to see, not only in communities of color, but knowing that we have moms and women from different varying backgrounds that are advocating for other women. Like, you all are amazing in everything that you do, and I'm just very honored to even know you all. Thank you, thank you, thank you, thank you. So we did want to have, you know, a question and answer period, but we only have 2 minutes left. So I would love to just wrap with one question, and if you guys can limit your answers to about 30 seconds. How would you all as panelists encourage other mothers to continue to be advocates for themselves right now? Like, what is one piece of advice you wish you would have received during your pregnancy?
Should I go ahead and go first? Okay. So I would just say to consult, you know, I'm known for being not very assertive. I'm not an assertive person. I can be pretty laid back and go with the flow with just about anything. But even me as a mom and as a doula, consult with somebody. Get informed on, you know, what the policies are, what's allowed right now, and have your information. Say, you know, if you go to your appointment, say, this is what I'm hearing is going on. Is this what it is? Can I depend that this is accurate information right now? And just really just stay informed. Don't do overkill with all the media and stuff. Just stick to the facts, stick to the basics and the things that pertain to you to get your questions answered.
Wonderful. Nadia?
Yeah, I think, you know, it's really important to get information that's just not random. So yes, you can go to the CDC, World Health Organization, just to get information of what's officially out there, so you know what the hospital should be doing. But also there's organizations like Ancient Song in New York City, Black Mamas Matter Alliance. You could Google these organizations, Moms Rising, just look what they're saying as well, right? Because they're the advocates who are there for you, not just for the bottom line of a hospital or provider. So, you know, you can Google, but please try to go to official sources or advocacy sources to inform yourself and say, no, this, I know that this is right now what's happening, and keep checking it, because it is changing, but I do think it is stabilizing a little bit.
Thank you. Ashley?
Yes, I would say believe in yourself, get the facts as well. I'm piggybacking off of Shayna and Nadia. Definitely, you know, you want to definitely get the facts. Clarify exactly what you want as well.
Lastly, Dr. Yatende?
I would say piggyback off the rest of these ladies, you know, definitely just be mindful of your references, but yeah, there are publications out there that can guide you along the way. And like I said, find a trusted professional, because there's nothing that's going to replace a trusted relationship between you and your doctor.
Wonderful. And of course, utilize us. Melanated Moms also is a huge resource. If you go to our page, melanatedmoms.com, and go to Melanated Resources, we have 3 specific areas where we do provide support and resources to the community. We have support groups that are actually going to be starting virtually, starting August 1st. Our second resource is find a resource, be a resource. If you are a community-based organization or any type of provider of a service for other moms and women, please utilize that second option and fill out our form so that we can add you to our directory. And last but definitely not least, we are creating a workflow to create an integrated health model that we want to present for the state of New Jersey to improve birthing outcomes. We want to marry holistic health and clinical care and placing the pregnant person at the center of attention to make sure that they have comprehensive health care that addresses their physical needs, mental needs, as well as any other social determinants that may present as a barrier. So absolutely utilize Melanated Moms. Because we did run out of time, I will be able to offer the Find Your Roar training on a different date. So I will coordinate with Advocates of New Jersey to be able to present that, and we'll make sure to post that for anyone who is still interested in attending the training, because we definitely want you all to still be advocates for yourselves and for others. And last but absolutely not least, we want you to remember, the call to action for this particular event is to talk about how to advocate for maternal health. And Advocates for New Jersey is hosting the Strolling Thunder event, which takes place August 5th. It is also a virtual event, and we want you to be a part of it. So go to acnj.org right now and sign up to register for the event. You can also sign up to speak or to even give your opinion. But again, reach out to us. We're here for you. We are only going to be able to advocate if you are a part of that conversation. So go to acnj.org and also go to melanatedmoms.com, to learn more information and to also be a part of the discussion. It does not end here, and we know that everything we do cannot be a singular event in order to create the change that we want to see. So I appreciate you for giving me an additional 4 minutes of your time. My name is Jay Wilson. I am the founding president of Melanated Moms. Have a wonderful, great day, and continue to advocate for the moms that we need, or for the moms that we have, because that's what we need. Thank you.
Thank you very much, Jay.
Thank you all.
Thank you. Have a good day.